So early is the most. So thank you very much for the panelists. What I wanted to come out of this is that how important it is to really use and utilize what knowledge we have in terms of testing for our patients rather than using expensive drugs in the wrong setting for our patients. I think it is very important. Dr. Dior, do you want to comment?
I wanted to make a comment about the testing because there are some very limited series in colon cancer, but it's more advanced in lung cancer, which is testing of circulating free DNA from a blood sample. And this will shorten the delay because we are bypassing the step of the pathology. So the blood does not have to be de-archived and cut and the tumor delineated and sent to the lab. And if we just draw a blood sample, it can also be done from the urine with the same efficiency.
Okay, thank you very much.
Thank you very much for this nice exercise. It was some way also a summary of, at least in part a summary, something contradictory to what we have discussed this morning. Thank you very much, Professor Wachter. Now we come to the next topic, peritoneal metastases. This is a distinctive biology in colorectal cancer. Some of them are only peritoneal, others are coming from other metastases, going to peritoneal, and now we hear what that is, what that means, and what we have to do. Thank you.
Thank you. My name is Ahmed Abdelaziz. I'm one of the consultant oncologists. I'm a lecturer at Shams University. This is going to be short. I promise I will not keep you long from dinner. It's been a long day. We'll change gears here and we'll talk about peritoneal carcinomatosis. First, I'll start to give a brief background about epidemiology and the prognosis of this disease. So it's approximately 25% of all patients with colorectal cancer develop peritoneal carcinomatosis during the course of their disease. And around 10 to 15% of patients with colorectal cancer already show peritoneal carcinomatosis at the time of the diagnosis. That's roughly 1 in 7 or 1 in 8. And we know now that peritoneal carcinomatosis is generally associated with a poor prognosis. Earlier today, Mr. Verwal has demonstrated to us how peritoneal carcinomatosis is associated with poorer outcomes, and we've seen this consistently in multiple clinical trials. I brought here a couple. The first one is the Dutch Eindhoven Cancer Registry, where they looked at 1,074 colorectal cancer patients, and they then looked at this particular group, and they found in the 200 patients that they did significantly worse. This was also demonstrated in the Cairo 2 trial. If you have metastatic colorectal cancer patient with peritoneal metastasis, then survival is 15 months. If you don't have peritoneal metastasis, survival is around 21 months. This was also seen earlier in the Cairo 1 trial, which looked at the best sequence of chemotherapy in this group of patients. In the GCO, we have a pooled analysis, and this was 2 years ago. This is essentially the pooled analysis of the central cancer treatment, the North Central Cancer Treatment Group, phase 3 trials, N9741 and N9841. The first one was looking at the first-line chemotherapy in metastatic colorectal cancer patients, while the second one looked at the optimal chemotherapy combination in the second line. And as you can see here, the graphs are self-explanatory, and they show how this group of patients have an adverse prognosis. So we'll try to utilize the presence of our group of experts here to guide us on the best way to manage or to treat this challenging presentation. So this is an imaginary case. So Mr. JWM is a 50-year-old solicitor. In 2013, he's had left hemicolectomy for a grade 3 T4A N0 adenocarcinoma of the descending colon. And this was followed by adjuvant 5-FU, the Degramont style. On regular follow-up, the CAA has been well controlled for 2 years. But recently, after an nadir of CAA 1.4, it started to creep up, going to 6 and then to 25. On examination, nothing was palpable, and staging CT scans did not demonstrate any organ metastasis or lymph node metastasis. However, there was small volume peritoneal metastasis in the anterior abdominal wall. PET scan showed FDG avidity. So unfortunately, this patient's cancer has come back. And to summarize, this is an active 52 years old chap, working full-time, no comorbidities, excellent performance status, and he has low volume intra-abdominal disease, 3 peritoneal nodules. So I don't know if we have a radiologist among the panel or not, but we wanted to explore first what would be the best way to stage these patients. We know that peritoneal metastases are difficult to quantify in CT scans, and particularly if you have a slim or patient with low body mass index with no intra-abdominal fat, interpreting the CT scan and peritoneal metastasis is difficult. So I don't think we have. Do we have a radiologist among the panel? All right.
I think.
So can I ask Professor Gira, what do you do to stage your patients before considering any further management?
You mean I'm the closest person to a radiologist?
Sorry?
For staging, I think we need to discover what's behind. These 3 nodules are probably the tip of the iceberg, and we were discussing together. I think the best is to do laparoscopy at this stage to see how far the disease is. That's my guess.
So it's part of your routine to do a staging laparoscopy for all patients? I mean, consider for
No. I'm not saying routine. It depends what is what you expect to do. What are your decisions to be made?
Excuse me.
So
This means you will do laparoscopy for every patient if the CT scan is negative.
no, actually, my initial question was about the best radiological way to assess peritoneal metastasis and whether we need to implement MRI as part of our staging for these particular patients or not.
We have a surgeon in the panel, by the way.
Could you?
Yes, I think further investigations would depend upon what you are going to do for that patient. If you are sure that you have a peritoneal carcinomatosis and you are going for systemic chemotherapy, there is no need for staging laparoscopy. I think the stage for assessment laparoscopy must be before what we detect radiologically by CT or PET-CT. When you have a raising or rising markers, it is a very good time for laparoscopic assessment at that time, because the disease is always more extensive than what we see on CT or PET-CT. So if you are going to have chemotherapy or systemic chemotherapy, you start immediate treatment. If you are looking for something surgical for peritoneectomy and HIPEC, we will go for that.
I'm coming to this in a second.
Yes, so
I just wanted to know if we agree here if these patients should have...
decision first.
All right.
So just for clarification, this is if you have this CT or MRI, then you would not make a laparoscopy because it's not going for surgery. But if you decide for surgery as an option, then you have to do laparoscopy before. Yes. So first step is MRI or CT. Who can tell us this? MRI.
Right.
And this is the next step if you think it might be an approach for HIPEC and so on.
Exactly, thank you. So, Professor Schmoy, so you recommend an MRI scan for these patients?
Yeah.
All right. So, now my first question is, in this patient, again, he's a young patient, is working full-time, good performance status, no comorbidities. So what would the panel recommend for this patient? Is it a radical approach or a palliative approach?
Everybody has seen this the imaging To make a decision on curative or palliation? Okay, let's vote. A is 1 and B is 2.
A is curative and B is palliative.
Yeah, 1 and 2. We have no
Yeah.
A, B here. We've got 1, 2. Oh, that's it. Yeah.
You're not making it any easier for me.
Hey, will you explain who is right and who is wrong?
Well, there's no right and wrong.
Can you go back to the image? To the MRI? Yeah, CT. Is there a radiologist here? So these are multiple nodes?
These are 3 anterior abdominal peritoneal nodules. These are all that we can see, and on the PET scan they were avid.
But normally the peritoneal carcinomatosis is not showing really in PET scan, only if it's really big nodes. The more smaller lesions and the broader lesions that do not appear in PET. So PET is not a good. It's
a good tool.
By the way, the wrong approach. You don't need this. It's just if you want to see real, then you have to look by yourself. Laparoscopy.
All right. So you wouldn't rely on a PET scan instead
No,
of these patients?
PET is not helpful.
All right. So half of the panel recommended palliative approach and half recommends a curative approach. So if we're going down, those who opted for a curative approach, would you consider, we've addressed this earlier, would you consider laparoscopy for all those who are going to be managed radically? Surgical pan, do you consider?
Yes, for minimal peritoneal disease, we can consider laparoscopy for management in some cases. Very highly selected cases can be managed laparoscopically, particularly very early disease with minimal BCI less than 5, we can go for laparoscopic management followed by further treatment, of course.
Professor Lahul.
Yes, I think any laparoscopy should be delayed after the initiation of the maximum intensity chemo plus or minus doublet, and then assess the response after, say, 2 months or so by the laparoscopy in preparation for possible surgery, because we usually see in our clinical practice some fantastic responses. It's not only in the peritoneum, but sometimes in the liver and sometimes in the lung. And sometimes we are considering the case as a stage 2 according to the ESMO classification. And by time, it proves to be just a group 1 and not group 2. So sometimes we see fantastic response. So for the local surgery and the preparatory to it, the laparoscopic examination or so, we can do it not upfront, but after the intensity chemotherapy.
Yes.
I agree completely. The chemotherapy is the first step, and then you have to see whether the rest is resectable or not. And this needs laparoscopy after chemotherapy when you see response. Or if you make really good, excellent, then it's before and after. But in principle, you need always the chemotherapy before, otherwise it's outcome poorer. Just a question: have you some ideas in the floor? Have you some contributions, some comments, please? Microphone comes at the same time.
I think my opinion, we may do laparoscopy at front because we are not quite sure of the diagnosis. Maybe the SUV is not high. It is just about 2 or 3 this PET scan. So the next thing is to compare my result of the chemotherapy. I have to do it before chemotherapy and after chemotherapy to show the exact result. Maybe I show something after chemotherapy and it says this result. I don't know what is the baseline of peritoneal metastasis. So I think that maybe, this is my opinion, my proper way is to do it before and after.
But you do a chemotherapy anyway.
I get chemotherapy anyway, so I want to know, to compare the result, compare my result of chemotherapy. So I have to see image of what I have before I start the chemotherapy. This is my opinion.
Okay.
Well, actually, Professor Alak.
Can I just have a comment and a question to Professor Schmoll and our other experts? I mean, I definitely agree to what you mentioned about starting systemic chemotherapy and then do evaluation to go for further surgery. But don't you agree that there is some or certain subpopulation of those patients who have a full resectable disease to start with, even if they have peritoneal metastasis, and they're better off going for surgery to start with and then systemic adjuvant therapy at that time, or you don't see this subpopulation of patients?
Actually, this is coming to the next stage of the case, if you don't mind.
Okay.
Just comment على عمرو
let me comment on your question.
I have a comment.
It was normal. If the CA was normal, I would do laparoscopy for diagnostic maybe. But if the CA is quite high, so laparoscopy in this scenario will not vary.
Okay, that's another topic. That's difficult to discuss like this. But this is another topic, a CA question. It will now be more and more complicated. But what is reality?
Dr. Mohammed Hassan. The panel have been divided completely to either palliative and curative, and that's why everybody defend on the curative intent will do everything to enter the patient on a maximum response, and then to prepare himself, the committee can be prepared himself, multidisciplinary committee, to compare the response. And that is why Dr. Amr Lotfi defend the doing laparoscopy up front. Laparoscopy up front will not add anything except to have a very good comparison later on. For me, I vote for curative intent because of no comorbidity and young age, and that is why I would like to do everything. But if the story is 70 years old with a very little comorbidity, maybe this all tools is not mandatory.
Yes, so even if you have a resectable disease, you still need to start with chemotherapy, even if it's resectable. So you start with, and you'll give like 3 cycles, and then you can assess the patient.
Basically, I did agree to that. That's what I said. And I'm just talking about a certain, maybe small subpopulation of patients who would be better off starting with surgery. This is what I'm talking about. But basically, would go for systemic chemotherapy to start with.
My question and my comment also. Now we have 2 lines of treatment, and not only systemic chemotherapy as the primary or the only treatment for that. Either we have the plan to have cytoreduction completely followed by intraperitoneal hyperthermic chemotherapy to be followed after that with systemic chemotherapy, and this is what's done in many centers now all over the world. Or you decide to have systemic chemotherapy as the only line of treatment, and you go for second loop operation after that for final assessment for your response, not only by markers or CT, and you go for intraperitoneal hyperthermic chemotherapy again. So we must have a complete multidisciplinary approach for this type of patients, not only to decide to start one line of treatment without having a further plan for that patient.
Thank you very much. Well, actually, this switch discussion.
Last floor comment, because it's very vital and very informative. Can you close your microphones, please? Can you, colleagues from the board, please. Can you close the microphone?
I would like to ask the panel the question of as we know that the systemic chemotherapy in peritoneal carcinomatosis is low, the response is low, and the prognosis is poor. What is the option of bidirectional chemotherapy, combining the intravenous chemotherapy plus intraperitoneal chemotherapy as a new adjuvant in cessation if a curative treatment intention is sought for? I would like to ask the panelists here about the...
Actually, this is my next question. For the panel.
Yeah. The panel.
Right,
this is an option.
It's coming in the next question. Could you wait for this?
Yeah. So bidirectional chemotherapy, it means that you combine both, and as a new adjuvant, intraperitoneal plus systemic chemotherapy. This is to maximize the response of the tumor by directly attacking the tumor by intraperitoneal approach as well as the intravenous approach through the blood. So this is a method which is performed now for gastric carcinoma, because gastric carcinoma peritoneal carcinomatosis is poor, and this type of tumor is responsible for chemotherapy as well. If this can be done for this case, is that applicable? Instead of using systemic chemotherapy and aggressive approach, we can use the two approaches as well.
Thank you very much for this further option. This is an experimental option, but not, you can call this probably standard, but this is an experimental option. It's only in trials done.
Thank you very much for all
Can you just add, before we vote on this question, which is very nice, can you add D, number 4, and number D, with chemotherapy followed by surgery, HIPEC, and systemic? So it's a fourth option which we have discussed here and mentioned. If we vote, we should have a number 4. So for voters, just consider the 4 means starting with chemotherapy and then
standard palliative chemotherapy, single modality. Yes.
So we have 4 options now to vote.
All right.
Vote.
Can IT help us with that? Can you add a 4th option to the panel for a systemic chemotherapy one?
No, just by voting number 4 for you, so or D. So the A, B, C, or D, one of the 4 for voting. Number 4 is first chemotherapy.
So we have 4 options. One is just monomodality surgery only. Second option is surgery and HIPEC. Third option is your 3 treatments altogether: surgery, HIPEC, systemic chemotherapy. And I'm not talking about sequence at the moment.
No, the sequence, just right. So we can.
Okay. So can you?
A, B, C, D.
Can you raise?
Just let's vote.
Yeah. So who would go for 4? Just systemic chemotherapy, palliative chemotherapy.
By hands? My goodness. You can vote like this. 2, 3, 4, 5, 6. So we can also vote. Let's vote. No, let's vote.
Right.
Come, let's vote now on this question with an A, B, C, and D as.
Yeah, we've added D as palliative only chemotherapy.
Oh.
So actually half of the panel, or more than half of the panel, would just recommend systemic palliative chemotherapy. Right. So can we just stop here for a second and ask what would be the best treatment? Would you treat these patients any differently than how you treat the rest of the colorectal cancer patients in terms of your choice of systemic chemotherapy? I'm asking Professor Schmoll.
Yes, this is a good case, good example that you should do this differently. It's a different approach. The chemotherapy selection for the upfront chemo, I would not make a difference to all other approaches which are curative intent. That means the most active chemotherapy. We know that bevacizumab is active in the peritoneum and at certain pleura. The chemotherapy is better working with bevacizumab, and the anti-fusion effect is strong there. So I would prefer for example, in this patient, the folfoxirib bevacizumab is the most active combination for all patients.
All right. There was also some data from the North Cancer Center trial that I demonstrated earlier that showed that there might be slight improvement with oxaliplatin over irinotecan, but this was not replicated again. So regardless of the antibody, do you have any preference in terms of chemotherapy option, oxaliplatin versus irinotecan for this group of patients?
Myself, no, but as I said, the combination for that regimen is my preference.
Oh, right.
In this case. As long as I go for surgery. If it's just palliation, then it's not so.
The NCCN guideline 2015 says that HIPEC is still investigational treatment. It's not the standard treatment. And the standard treatment with carcinoma is chemotherapy.
Mm-hmm.
This is the last version of the NCCN guideline. Still investigation is not the standard of care.
Right. Yeah, absolutely agree. It's the standard of care so far is systemic chemotherapy. This is by definition an M1 disease. It's metastatic. But what we're talking here about, what could be potentially challenging in the clinic for a surgeon or an oncologist is a young patient with low volume disease, and that's why we are trying to brainstorm here and see if you would treat these patients any differently than you would treat a metastatic cancer patient. So going back to the order of treatments, if you would ever consider a radical treatment, a radical approach, is there any preferred sequence of treatments? And would you consider an upfront systemic chemotherapy to control microscopic disease? And then those who would stand this test would qualify for a radical approach? Or if you are thinking of a radical approach, would you do it upfront and keep chemotherapy to a later stage? And then we have a third option, is just surgery followed by systemic chemotherapy. So those who opted for the radical approach from the beginning, do they have any kind of preference to the sequence of events?
Before we answer, is there any discussion, questions, comments to this?
I mean, they're all right, but my point, which I insist on, I mean, there is a difference between extensive abdominal peritoneal disease and a patient who presents with only 3 lesions. These are completely 2 different patients, okay? So I respect the guidelines, but if this patient has a low burden disease with only a minimal, after laparoscopic evaluation, 3 limited, he can go for surgery, have a good, complete surgical excision, and then whatever HIPIC and systemic chemotherapy. But the other type of patient who has extensive abdominal peritoneal disease should definitely go systemic chemotherapy to start with. This is my point.
Thank you. Obviously, the panelists have different views, and this is why we're discussing such an ambiguous presentation, which actually poses a challenge for oncologists and surgeons. Professor Douillard, now we have the PRODIGE 7 from
Yes, I just wanted to make a comment. In my experience, when you see 3 or even 4 nodules in the CT scan, it means that it's not a low volume disease. These patients where they have a laparoscopy or laparotomy actually are found to have micro deposit everywhere. When it's visible on the CT scan or any imaging, peritoneal carcinomatosis is advanced.
So in your center, which patients might be considered for a clinical trial like a PRODIGE 7?
Well, any eligible patient will be offered to participate to a clinical trial. That's kind of a reflex. I am not very familiar with the PRODIGE 7 because there is a dedicated oncologist working with a surgeon accruing for PRODIGE 7, but we try to put the patient on clinical trial as much as we can. And this is occurring right now.
Some other comments?
Yes. I don't think you have something called partial peritonectomy. So if you have small peritoneal tumor, you do either nothing or you do total peritonectomy. Am I right or not, from the surgical point of view?
Yes, on segment 6, it is an easily resectable disease that can be taken with what we are doing regarding cytoreductive surgery and our plan to have intraperitoneal chemotherapy, as it is not a contraindication to have single easily resectable disease. But I think in this case we must have PET-CT also to be sure that this, what we see in MRI, is an active disease, or we have something else in the liver or outside the abdomen, before going to this, to what we are planning to have as a local treatment for this disease.
What happened? Did we vote for the previous question? We didn't vote.
Please.
No, can you go back? No, before. No, the previous question we did not vote. The slide back, this one. This, back.
Which one?
Next, this one. Keep on this. We did not vote on this.
Please do.
Yes, let's vote on it. It's okay.